fluid and electrolytes, balance and disturbance. Fluid balance is necessary for life and to maintain homeostasis. The nursing role is to anticipate, identify, and respond to possible imbalances. So make sure as you're following through this, you're keeping these things in mind when you are writing notes. Approximately 60% of the typical adult is fluid. This will vary with age, body size, and gender. We have intracellular fluid, which is 2/3 of our body fluid. We have extracellular fluid. We have intravascular, which is our plasma, erythrocytes, leukocytes, and thrombocytes. We have interstitial fluid, which is our lymph fluid. And we have transcellular, which would be like our cerebral spinal fluid, our pericardial fluid, and synovial fluid. Electrolytes are active chemicals that carry positive cations and negative anions, or electrical charges. The major cations are sodium, potassium, calcium, magnesium, and hydrogen ions. The major anions are chloride, bicarbonate, phosphate, sulfate, and protonate ions. Our electrolytes are going to be expressed in terms of milliequivalents. Electrolyte concentrations differ in fluid compartments. Movement of fluid through capillary walls depend on hydrostatic pressure, which is the pressure exerted on walls of blood vessels, and osmotic pressure exerted by protein in plasma. Direction of fluid movement depends on the differences of hydrostatic and osmotic pressure. So osmosis is an area of low concentration to an area of high concentration. Diffusion, so fluid moves from a higher area of concentration to one of lower concentration. Filtration is the movement of water. Solutes occur from high hydrostatic pressure to areas of low hydrostatic pressure. And active transport is the sodium-potassium pump. We will maintain higher concentrations of extracellular sodium and intracellular potassium. So we can have routes of gains and losses. For gain, healthy people gain fluids by drinking and eating. The daily intake and output of water are equal. Loss, kidney should excrete a urine output of 1 milliliter per kilogram per hour. So if you're 74 kilograms, you should have 74 milliliters of urine output per hour. We can also lose through our skin due to sweating, or excessive loss due to fever, exercise, and burns. Our lungs expel 300 mL every day, and it's going to be greater with increased respiration. The GI tract can have very large losses due to diarrhea and fistulas. Gerontological considerations. Clinical manifestations of imbalance may be subtle. Fluid deficit may cause delirium because they may already have decreased cardiac reserve, so elderly people can have an increased rate of decline with very small losses of fluid. They already have reduced renal function. Dehydration is very common. and age-related thinning of skin and loss of strength and elasticity also contributes to losses. We have fluid volume deficit and fluid volume excess. So deficit may occur alone or in combination with other imbalances. There's going to be a loss of extracellular fluid and because it's exceeding the intake ratio of water. So that's electrolytes can be lost in the same proportion as they exist in normal body fluids, or they might be lost in excess of the body fluids. So dehydration is not the same as fluid deficit. Loss of water alone will have increased serum sodium levels. The patient will. The abnormal fluid losses are caused by vomiting, diarrhea, sweating, GI suctioning through an NG. Decreased intake can be caused by nausea or lack of access to fluids. Third space fluid shifts can be due to burns or ascites. Additional causes may be diabetes insipidus, adrenal insufficiency, and hemorrhage. The clinical manifestations of fluid volume deficit can actually develop very rapidly, especially in our elderly. Severity depends on degree of loss. And we're going to see table 13.4. We have fluid volume deficit, the contributing factors, and then the signs and symptoms. So I'll let you review that. And also of excess. That's what we're going to talk about next. So fluid volume deficit management, we are going to do intake and output at least every 8 hours, sometimes hourly depending on our company policy, and more frequently if someone is definitely having less output than they need or less input than they need. Daily weight is the most accurate form of fluid assessment. The vital signs should be closely monitored. We're going to also assess for skin and tongue turgor, mucosa, urine output, and mental status. We're going to do measures to minimize fluid loss. We're going to administer oral fluids and parenteral fluids. Fluid volume excess. So there's an isotonic expansion of the extracellular fluid caused by abnormal retention of water and sodium in approximately the same proportions in which they normally exist in the extracellular fluid. So it's usually secondary to an increase in the total body content, sodium content. Causes of fluid volume excess can be due to fluid overload or diminished hemostatic mechanisms. So heart failure, kidney injury, cirrhosis of the liver. Contributing factors can be consumptions of excessive amounts of table salt or other sodium salts, excessive administration of sodium-containing fluids. The clinical manifestations of fluid volume excess are edema, distended neck vein, or we also call that jugular vein distension, crackles, and you can go back and see that table again for more symptoms and lab findings. Fluid volume excess, nursing management. We're going to do ins and outs, daily weights again. We're going to assess lung sounds, edema, and other symptoms. We're going to monitor the response to medications, including diuretics and parenteral fluids. We're going to promote adherence to fluid restrictions. The patient teaching related to sodium and fluid restrictions. We're going to monitor and avoid sources of excessive sodium, including medications, and we're going to promote rest. So this is just a list of electrolyte imbalances and their names. So on the hypo, of course, means too low, and hyper means too much. So we have sodium, calcium, potassium, magnesium, phosphorus, and chloride. We're going to talk about all of this. So hyponatremia is a serum sodium less than 135 milliequivalents per liter. It's usually it's an acute problem. You can't go wrong with this problem. It's a result of fluid overload, particularly most of the time in surgical patients, but there are other reasons. Chronically, it can be seen outside of the hospital. It's happened for a longer duration. It might be less serious neurologically, and it can be exercise associated. It's more common in women of small stature. It's common in extreme temperatures or excessive fluid intake. There's actually some mental illnesses that cause people to drink excessively, and they can get hyponatremia, and prolonged exercise can also cause this. So again, causes can be imbalance of water, losses by vomiting, diarrhea, sweating, diuretics, adrenal insufficiency, certain medications, and SIADH, and we'll be talking about that later. So that's syndrome of inappropriate antidiuretic hormone. It comes from your pituitary gland, usually caused by intracranial pressure issues. Manifestations are poor skin turgor, dry mucosa, headache, decreased salivation, decreased blood pressure, nausea, abdominal cramping, and neurological changes. So we're going to treat the underlying condition. We may give sodium replacement. There may be water restriction. There are medications such as basically salt tablets. We will be assessing the I's and O's, the daily weight, lab values, and CNS changes. We're going to encourage dietary sodium. So those salty chips and things that we add table salt to, like canned vegetables, are okay for them, and canned soups, lunch meat. We're going to monitor fluid intake and the effects of medications such as diuretics or lithium, because they can be big causes of hyponatremia. Hypernatremia is sodium greater than 145 milliequivalents per liter. Occurs in patients with normal fluid volume deficit, and fluid volume excess. Most affected are very old or very young and cognitively impaired. Some of the causes may be fluid deprivation. So we were talking earlier today about the elderly who lose their drive to drink and to eat. Excessive sodium administration. So this is when a person who is getting repeated boluses of normal saline. Diabetes insipidus. Again, a problem of intracranial pressure on that pituitary gland. And then heat stroke. Hypertonic IV solutions can also cause this. Manifestations are thirst and elevated temperature. Also, we're going to gradually lower the serum sodium level via infusion of a hypotonic electrolyte solution. We do not want their sodium to return to normal quickly. That can cause more problems, so it's going to be a slow lowering of serum sodium, usually over a few days. They may receive diuretics. We're going to assess for abnormal loss of water and low water intake. We're going to assess for over-the-counter sources of sodium, and we're going to monitor the CNS changes. Next, we'll do hypokalemia, which is our low serum potassium. This is usually less than 3.5 milliequivalents per liter. However, you will see in the hospital they often treat patients who are even a little bit higher than this. They do not want patients to get this low because it will cause dysrhythmias, especially in your cardiac units, ICUs, PCUs. They will have potassium replacement protocols, so make sure you ask your fellow nurses to show you what that looks like. So it may occur with normal potassium levels. When alkalosis is present, a temporary shift of serum potassium into cells occurs. So we were talking earlier about metabolic and respiratory alkalosis. We can have hypokalemia. So our causes are GI losses, medications, prolonged intestinal suctioning, which would be our NG suctioning, recent ileostomy, because those have a very large volume of loss, tumor of intestine, alteration of acid-base balance, there's our alkalosis, poor dietary intake, and hyperaldosteronism. You will see EKG changes. They are generally going to be tinted T waves in your EKG. You may also see dysrhythmias. The urine will be very dilute. Your patient will have excessive thirst, fatigue, anorexia, muscle weakness, decreased bowel motility, so they'll be constipated, and paresthesia. They have difficulty feeling, usually in their extremities. The management is potassium replacement. So we'll increase their dietary potassium or IV or oral pills, or there's even a solution for our patients who have to take it via G-tube or NG or CORTRAC. We're going to monitor for ECG changes. So if anyone has hypokalemia, you can better bet they're going to have cardiac monitoring. We're going to monitor ABGs. We'll monitor patients receiving digitalis for toxicity, and we'll monitor any early signs and symptoms of changes. We're going to administer IV potassium only after adequate urine output has been established. Hyperkalemia is a serum potassium greater than 5. It seldom occurs in patients with normal renal function. It is increased risk in older adults. Cardiac arrest is frequently associated, so you better bet they need to have EKG monitoring or cardiac monitoring. The causes are impaired renal function. If the potassium is administered too rapidly, it can also cause hyperkalemia. Hypoaldosteronism, medications, tissue trauma, and acidosis. Remember, we're hyper on acid, so we have hyperkalemia. We have manifestations or cardiac changes and dysrhythmias. We have muscle weakness, paresthesias, anxiety, and GI manifestations. We're going to monitor their ECG. We're going to assess labs, monitor INO, and obtain apical pulse. We're going to limit dietary potassium and dietary teaching. So remember to look up foods that are high in potassium. We're going to administer K-Exolate. This is a medication that helps draw the potassium out into the bowel, and they excrete it through stool. And its emergent care would be to deliver IV calcium gluconate, also IV sodium bicarbonate, and IV regular insulin followed by a hypertonic dextrose IV. We're going to learn how to do that. Also albuterol, our beta-2 agonist, and dialysis also all these things will decrease the potassium. Remember, when you do administer potassium, that you're going to give it very slowly and with an infusion pump. Hypocalcemia, that's serum level less than 8.6. It must be considered in conjunction with serum albumin level. Serum calcium level is controlled by the parathyroid hormone and calcitonin. So it's very important, especially when we study thyroidectomy and parathyroidectomy. Causes are hypoparathyroidism, malabsorption, osteoporosis, pancreatitis, alkalosis. Remember, we have hypocalcemia and alkalosis. And then we have transfusion of citrated blood, kidney injury, and medications. The manifestations are tetany. That's where all of our muscles are getting stiff. They'll have circumoral numbness, so you'll get around their mouth and lips will become numb and tingly. They'll have paresthesia. They'll lose feelings, especially in their extremities. We'll have hyperactive DTRs. You'll have Trousseau sign and Chauvet sign. I have pictures of those later. Seizures, respiratory symptoms of dyspnea and laryngospasm, and abnormal clotting and anxiety. So it's extremely serious. So Trousseau sign, if you have the blood pressure cuff on them, it kind of makes their hand go into like a deformed, like kind of I don't know how to describe that, but there's a picture of it. So it's kind of like a bent wrist and bent elbow, and your thumb comes up. It just kind of makes your muscles kind of twitch into that situation or contract. And if the Chauvet sign is if you touch their cheek, it makes their face twitch into like a side grimace. So it's all about that tetany and tightening of muscles. It's that hypertonicity. Management of hypocalcemia, we give IV calcium gluconate for emergent situations. Otherwise, we give oral replacement. Seizure precautions, they may have oral calcium and vitamin D supplements. They also may have supplements for, it's called calcitriol to help the kidneys retain calcium in the body. They will have exercises to decrease bone calcium loss, and lots of patient teaching related to diet and medications. Hypercalcemia, that's a serum level greater than 10.2. Hypercalcemia crisis has high mortality. Usual causes are malignancy, and hyperparathyroidism. They may have bone loss related to immobility, and also diuretics may cause this. So the clinical manifestations are polyuria, that's frequent urination, thirst, muscle weakness, intractable nausea, abdominal cramps, severe constipation, diarrhea, peptic ulcers, bone pain, ECG changes, and dysrhythmias. They are definitely going to be on cardiac monitoring. We're going to treat the underlying cause. We're going to be administering IV fluids, furosemide, phosphates, calcitonin, and biphosphonates will be delivered. Will increase their mobility, will encourage fluids, will do dietary teaching and fiber for constipation, and ensure safety. So a lot of the reason is they may have a tumor or dysfunction of their parathyroid gland, and a lot of times they will have to go in and surgically remove one to not have so much serum calcium. Hypomagnesemia is serum less than 1.3 milligrams per deciliter. It's associated with hypokalemia and hypocalcemia, often with our potassium protocols. If the potassium is lower than 3.5, we'll also check a magnesium level. Causes can be alcoholism, GI losses, enteral or parental feeding that is deficient in magnesium, medications, rapid administration of citrated blood. Manifestations are trophic sign and Trousseau sign, apathy, depressed mood, psychosis, neuromuscular irritability, muscle weakness, tremors, ECG changes, and dysrhythmias. With hypomagnesemia, we're going to administer magnesium sulfate with an infusion pump, and we're going to monitor vital signs and urine output when we're delivering it. There are oral magnesium supplements as well. We're going to monitor for dysphagia and seizure precautions, and we're going to do dietary teaching. So hypermagnesemia is serum level greater than 3.0. It's a very rare electrolyte abnormality because the kidneys efficiently excrete magnesium, but it can occur in kidney injury, diabetic ketoacidosis, excessive administration of magnesium, and extensive soft tissue injury. So that would be like our rhabdomyosis. Manifestations would be hypoactive reflexes, drowsiness, muscle weakness, depressed respirations, ECG changes, dysrhythmias, and cardiac arrest. So we're going to give IV calcium gluconate to counteract the hypermagnesemia. They will also probably receive hemodialysis. They will administer loop diuretics, sodium chloride and or LR. We'll avoid medications containing magnesium. Patient teaching will also include magnesium containing over-the-counter medicines. And then we'll have observed for DTRs and changes in LOC. Hypophosphatemia is serum below 2.5 milligrams per deciliter. It's often caused by alcoholism or refeeding of patients after starvation, pain, heat stroke, respiratory alkalosis, hyperventilation, diabetic ketoacidosis, hepatic encephalopathy, major burns, hyperparathyroidism, low magnesium, low potassium, diarrhea, vitamin D deficiency, and use of diuretics and antacids. So its manifestations are neurological symptoms, confusion, muscle weakness, tissue, hypoxia, muscle and bone pain, increased susceptibility to infection. The medical management is oral or IV phosphorus replacement, and the nursing management is assess for these changes, encourage foods high in phosphorus, and gradually introduce calories for malnourished patients receiving parental nutrition. Hyperphosphatemia is serum level above 4.5 milligrams per deciliter. It is often caused by kidney injury, excessive phosphorus, excess vitamin D, acidosis, hypoparathyroidism, and chemotherapy. Has very few manifestations, but they may have soft tissue calcifications, and symptoms occur due to associated hypocalcemia. They're in relation. So when your calcium is low, your phosphorus is usually high, and vice versa. The medical management is to treat the underlying disorder, vitamin D, calcium binding acids, phosphate binding gels. Renal gel is a very common one, or antacid, loop diuretics, normal saline IV, or dialysis. Nursing management would be including assessment of the symptoms, avoid high phosphorus foods. You need to look those up for your nutrition ATI. Patient teaching related to diet, phosphate-containing substances, and signs of hypocalcemia. Hypochloremia. The serum levels are less than 97. The causes for this are Addison's disease, reduced chloride intake, GI loss, and diabetic ketoacidosis. Excessive sweating, fever, burns, medications, metabolic alkalosis. Loss of chloride occurs with loss of other electrolytes, including potassium and sodium. Manifestations are agitation, irritability, weakness, hyperexcitability of the muscles, dysrhythmias, seizures, and coma. So it's important for them to have cardiac monitoring. Medical management is to replace the chloride via IV normal saline or half normal saline. We're going to be assessing them for any of these symptoms. We're going to avoid free water because that's just going to cause it to be worse. We're going to encourage high chloride foods, and we're going to teach the patient about high chloride foods in their diet. Hyperchloremia. Serum level is more than 107 milliequivalents per liter. The causes could be excessive sodium chloride infusions with water loss, head injury, hyponatremia, dehydration, severe diarrhea, respiratory alkalosis, metabolic acidosis, hyperparathyroidism, and medications. The manifestations are tachypnea, lethargy, weakness, rapid, deep respirations, hypertension, and cognitive changes. They'll have a normal serum and ion gap. Medical management is to restore electrolyte and fluid balance. And we often give them LR because it has not just saline in it, but it has some of our electrolyte replacements. They may have serum bicarbonate and diuretics. Nursing management is to assess for symptoms and do patient teaching related to diet and hydration. So maintaining acid-base balance, of course, our normal pH is 7.3 to 7.45. Major extracellular fluid buffer system is our bicarbonate and carbonic acid buffer system. The kidneys regulate bicarbonate in the extracellular fluid, and the lungs, under the control of the medulla of our brain, regulate CO2 and thus the carbonic acid in the ECF. So with acidosis, hyperkalemia may occur as potassium shifts out of the cell. As acidosis is corrected, potassium shifts back into the cell, and the potassium levels can decrease. So it's something we have to constantly monitor during acidosis. Serum calcium levels also may be low with chronic metabolic acidosis, so that would be our renal failure patients. So we must correct them before treating acidosis. So respiratory acidosis, they have a low pH, less than 7.35, and PaCO2 greater than 42. It's always due to respiratory problem with inadequate excretion of carbon dioxide. With chronic respiratory acidosis, the body may compensate and may be asymptomatic. So that would be our COPD patients. Symptoms may include suddenly increased pulse, respiratory rate and blood pressure, mental changes, and feeling of fullness in the head. And potential increased intracranial pressure. Treatment is aimed at improving the ventilation. In respiratory alkalosis, we have a high pH greater than 7.45 and a PaCO2 of less than 35. It is always due to hyperventilation. Manifestations can be lightheadedness, inability to concentrate, numbness and tingling, sometimes loss of consciousness. The best thing to do is to correct the cause of the hyperventilation. And so I just have again here the values, how to interpret those, and review the table on 13.5 on page 260 for IV fluid review. This will help you complete the worksheet.